Well, good afternoon, everybody. I'd like to start on time to be respectful of everybody's afternoon activities. Welcome to CWRH on the cutting edge, a window to the future. This is a first of what we hope will be many more to come. Descriptions of some of the work that some of the investigators in the CWRH are doing. Next slide, please. Thank you. So the speakers for today will be myself. I'm actually in Dallas right now at a DSMB meeting. Akila Subramaniam, many of you know, Christine Muzny, Teresa Boitano, David Kimberlin, pediatrics, and we'll finish up with Alan Tita. Next slide. Thank you. So I'm happy to be here representing Urogyne and plan to quickly present two areas of high research interest in Urogyne. Next slide. The State of the Science Conference on Overactive Bladder and Cognitive Impairment was an idea that I championed as president of the American Urogynecologic Society. This State of the Science occurred in Washington, D.C. in December of 2021. Next slide. As many of you know, OAB is a very prevalent condition in both women and men, having a prevalence rate of approximately 16%. And this prevalence rate doubles in women greater than 65 years of age. So we see a lot of it in our practice. It has significant negative health impact, and projected costs associated with it is over $80 billion per year, greater than both breast cancer and osteoporosis. Next slide. The current treatment of OAB currently follows a linear algorithm, including patient education, the use of behavioral therapies, pharmacologic meds, up to advanced bladder therapies. And third-party payers adhere to this algorithm, often not allowing advanced bladder therapies without first trying behavioral therapies, and usually at 2 to 3 medications. Next slide. So recent studies have, next slide. So recent studies have noted an increased risk of cognitive impairment in women who use oxybutynin for overactive bladder. This resulted in an AUGS consensus statement in 2017, where we educated patients about this and thought about using medications to lessen the anticholinergic burden. This was followed by a 2020 consensus statement, which updated these recommendations, including consideration of use of beta-3 agonists, medications that don't cross the blood-brain barrier, and a Choosing Wisely campaign, where we are stating that all women greater than 70 years of age should not be using anticholinergic meds for their overactive bladder. Next slide. So the SOS overarching goals were to understand the conservative treatments in older women, review the current evidence, discuss the current algorithm, and evaluate the evidence regarding use of other bladder therapies, especially in women at risk for cognitive impairment. Next slide. So moving forward, we hope to produce an evidence-based, multidimensional, go back to the last slide, please, comprehensive strategy that it has become an action plan to advance OAB research and treatment initiatives. We hope this results in an evidence-based algorithm that allows individualization of care. It's only by partnering with all stakeholders, including healthcare providers, scientists, funding agencies, patient representatives and advocacy groups, and industry partners that we will achieve success in this initiative, especially for our older patients. And this is ongoing. Next slide. So for those of you that aren't aware about what urogynes do, we take care of patients with prolapse, urinary and fecal incontinence, among other pelvic floor disorders. After a hysterectomy, a woman may develop prolapse at the apex of the vagina, called vaginal vault prolapse. little level 1 data exists for the surgical management of apical vaginal prolapse after hysterectomy. Next slide. Therefore, a trial was designed through one of our multi-site NIH networks, the Pelvic Floor Disorders Network. Next slide. We have 3 primary aims that had unique hypotheses. The first aim was to determine if the use of transvaginal mesh was non-inferior to sacrocolpopexy, which is the use of abdominally placed mesh that brings the vaginal vault up to the sacrum. So we wanted to to see if results were non-inferior between transvaginal mesh to sacrocolpopexy. We also wished to determine if sacrocolpopexy was superior to native tissue repair for this anatomic correction. And the third primary aim was to determine if transvaginal mesh is also superior to native tissue repair. Next slide. There were several secondary aims as well, including doing subjective and objective outcomes using validated measures, looking at safety and adverse events, predictors of outcomes, body image, as well as cost effectiveness. Next slide. So consented women were randomized 1:1:1, and repairs addressing anterior and posterior compartment defects, as well as incontinence, were allowed. Next slide. The primary outcome was a multi-component one, comprised of, and that is the women had to have all 3 of these components to be a success: absence of bulge symptoms, absence of retreatment, and no prolapse past the hymen. Next slide. The statistical considerations and analytic plan was interesting. The hypothesis test that drives the sample size is the test on non-inferiority of transvaginal mesh to sacrocolpopexy. And we saw a sample size of 121 participants per arm, provided 85% power to demonstrate non-inferiority. And then also assuming that 121 participants would be randomized to native tissue repair, the overall sample size of 363 patients will provide greater than a 90% power to demonstrate that each of the mesh augmented arms is superior to native tissue in terms of these outcomes. Next slide. Interestingly, the patient was masked till their assignment until after the surgery, and postoperative vaginal assessments were performed by co-investigators or nurses masked to procedure allocation. Obviously, it would be hard to mask the patient to one of these therapies. Next slide. So this is only 3 RCTs to this point have been performed for apical prolapse comparing sacrocolpopexy to native tissue, and they were very small studies. Likewise, only 1 RCT has been performed comparing sacrocolpopexy to transvaginal mesh, and this was very small. Next slide. So in summary, the 3-year data are to be presented at the Society of Gynecologic Surgeons meeting in Tucson in March of this year. We're very excited about this. We continue to follow these patients to get longer term outcomes, at least 5 years from this very important cohort. So looking forward to talking to you in the future about the outcomes of this trial. Thank you very much. Our next speaker will be Dr. Akila Subramaniam.
Hey guys, so today I'm going to present the findings of our pre-mod 2 study. I know a number of the residents are involved in this from a standpoint of they are the ones enacting the intervention. And so we're going to go over the kind of the 2 phases of this study in the next few minutes. So pre-mod 2 is premature infants, 28 to 32 weeks, receiving umbilical cord milking or delayed cord clamping, a randomized non-inferiority trial. The overall PI is Anoop Katharia, who's at Sharp Medical in California, and I am our current site PI. So what's the rationale for this study? So, we all know that according to ACOG, delayed cord clamping in preterm infants has been shown to be beneficial. But, when we have non-vigorous infants, even though it's found to be beneficial, umbilical cord milking might be an alternative. in that it can be done a little bit faster. So getting the benefits of that extra blood that has been shown to decrease things like IVH and NICU stay without delaying resuscitation. So the pre-mod trial originally, in the first part of this data, was previously presented at both at SMFM as a late-breaking abstract and is actually published in JAMA. The original pre-mod trial included 2 stratas of infants, a small strata between 23 to 27 weeks of gestation, and a larger strata, 28 to 32 weeks of gestation. So the enrollment in the lower gestational age strata, 23 to 27 weeks, and this has been published, was discontinued because when they did their interim analysis in this very small, like early gestational age, umbilical cord milking was actually shown to have an increase in intraventricular hemorrhage compared to delayed cord clamping. We hypothesize that this is due to the fragility of the cerebral cortex and the CNS structure of very small infants. So the standard remains delayed cord clamping. But we did not see these safety signals in a higher strata, and then this was continued. So what we're going to talk about today is the second iteration of pre-mod, which is the infants that are 29 to 32 weeks of gestational age who are able to continue to look at their short-term outcomes as well as long-term outcomes, which are currently being collected. So the primary objective of pre-mod 2 now, so this is exclusive of what was previously published, is to determine whether umbilical cord milking is non-inferior to delayed cord clamping in premature infants 28 to 32 weeks gestational age at delivery. Ideally, the delayed cord clamping was supposed to be over 60 seconds because that's what is the general standard of what is considered the best amount of time, but any delayed cord clamping was allowed. So it was a randomized controlled trial. It was multinational, so there were multiple centers in the US as well as in Europe, and it was a non-inferiority trial. This included preterm infants 28 to 32 weeks gestational age, and this was inclusive of those that were greater than 28 weeks from the start of the trial. So if you remember, when we started the trial, we had 2 strata. 1 strata was discontinued. The second strata was allowed to continue. And all data was analyzed using intention to treat principles. So the 2 interventions, one was umbilical cord milking, and as the residents are familiar with, the umbilical cord was milked 3 to 4 times as part of this protocol, and then delayed cord clamping. The primary outcome was actually a composite of 2 things, either death or severe intraventricular hemorrhage. And this severe intraventricular hemorrhage actually had to be certified by somebody reviewing the images. So it was a standardized outcome. The sample size was a total of 1,020 infants in this upper strata, and patients were enrolled from the beginning of the original trial, which is 2017, to September of 2022. So this trial is now complete. Adherence, this is great, but adherence to the randomization assignment was 95% in the umbilical cord milking group, which means if they were assigned to cord milking, 95% got what they were supposed to, and 93% in the delayed cord clamp group. So looking at key results here, so this is the table of results, and what you can see in the way this is depicted is the outcome is in the left column. The central left column has the 2 interventions, and then there's a p-value in the third column, and then the interaction value, which I'll talk to you about. So when looking at the primary outcome, which I've highlighted in this green box, there was no difference. So 1% rate of severe IVH or death in the umbilical cord milking group, 1% in the delayed cord clamping group. This was not significant with a p-value of 0.99. Where the last column comes to play is looking at, is there a difference in effect in our outcome based on whether infants were born via cesarean or vaginal delivery? And that p-value being 0.17 indicates that there were not. So this non-significance in outcome applied equally to both cesarean and vaginal deliveries. When you looked at the other outcomes, overall, there were no differences between in any of these secondary outcomes of just severe IVH, infant death, any grade ventricular hemorrhage, hemoglobin change, or hematocrit between the 2 groups. And those were all, like I said, not significantly different. The only difference that was seen on an interaction test is there may be, and this is not powered to detect this for sure, but there may be a different effect in intraventricular hemorrhage between the mode of delivery for severe IVH with potentially a smaller decrease in IVH associated with severe associated with cord milking and cesarean deliveries. but overall, a negative study showing that there was no difference between the two. So to summarize those results, in 28 to 32-week infants, there was no difference between cord milking and delayed cord clamping in terms of reduction of severe IVH or death and other short-term outcomes. There was also no increase in any adverse outcomes, which is important too. So the take home from this message was umbilical cord milking may be a safe alternative to delayed cord clamping for premature infants at this upper gestational age strata. With that, I'm going to turn it over to Dr. Muzny in infectious disease.
Hi, everyone. Thank you all for having me here today. Next slide. So I'm going to talk about two studies today that our team has worked on with regards to Trichomonas vaginalis. The first one is titled A Comparison of Single versus Multi-Dose Metronidazole by Select Clinical Factors for the Treatment of Trichomoniasis in Women. And I initially presented this study as an oral presentation at the Infectious Diseases Society of Gynecology. And here's a happy picture of a trichomonas taken by my PhD student, Keontae, in our lab here. Next slide. So the rationale for this study, we all know trichomonas is the most common non-viral sexually transmitted infection worldwide. 5-nitroimidazole drug class, which includes metronidazole and tinidazole traditionally, have been the mainstay of therapy. The optimal treatment in HIV negative women has previously been unknown. They had done a randomized controlled trial back in 2010 that got published in HIV positive women that did find that multi-dose oral metronidazole was more efficacious in HIV positive women. And so we had gone to using 7 days of metronidazole in that group way back then, but we're still using the single 2-gram oral dose of metronidazole in HIV negative women. So we had recently performed this randomized controlled trial here at UAB and some other sites looking at these two doses head to head in HIV negative women. So we basically found, all similar to HIV positive women, that multi-dose metronidazole was superior. So this study that I'm talking about here is a secondary analysis of the main clinical trial where we aim to determine if the effect was similar by select clinical factors. So if needed, we could target treatment recommendations. Next slide. So our primary objective was to perform the secondary analysis of our RCT data from the primary trial of HIV negative women to determine if the effect found regarding multi-dose metronidazole was similar by select clinical factors. We really wanted to look at hypothesizing that multi-dose metronidazole would be more effective, particularly for women with a history of trichomonas infection, symptomatic women, as we thought they would have a higher burden of infection due to trichomonas, and those who also had concurrent BV. Next slide. So the design of the trial itself, we enrolled women at STD clinics here in Birmingham, also in Jackson, Mississippi, and in New Orleans with LSU and Tulane. Inclusion criteria of the trial, they had to be cisgender women, English-speaking, 18 years of age and older. They had to have known positivity for trichomonas, either a wet prep or also a NAT test, a recent NAT test in the absence of treatment. Exclusion criteria, they could not be HIV infected. We did exclude pregnant or breastfeeding women. They could not be incarcerated because we had a test of cure visit in this trial. Also, if they had contraindications to the use of metronidazole. Also, if they had recently received antibiotics covering BV or trichomonas, and if they couldn't come to this test of cure visit. So in the parent trial, we enrolled 623 women overall. And we did have test of cure data on 540 women, and that's who got included in this secondary analysis. And half of those received single dose metronidazole and the other half got multi-dose. Out of this secondary analysis cohort, it's important to note that 15% of these people had a repeat positive test of cure, and the test of cure visit happened 4 weeks after the end of treatment in the trial. Next slide. So in these three figures here, I'll take the top one on the left first. So these are stratified analyses. So you can see in the top figure on the left side, women who were randomized to the single dose of metronidazole, which is the darker gray bar, had a higher rate of test of cure trichomonas positivity compared to those randomized to the multidose if they were symptomatic at baseline. The same was true on the top right picture for women who reported a history of trichomonas infection compared to those without. There was a trend for test of cure trichomonas positivity to be higher in women with concurrent BV who got randomized to single dose versus multi-dose, although this was not statistically significant. There were no significant differences among women who did not have these factors. Next slide. The table 2 on the left is the univariate unadjusted analyses examining the influence of these select factors and other factors on repeat positive test of cure for trichomonas. And in this analysis, women with a history of trichomonas had a greater odds of being repeat positive of test of cure than women without that history. And then women that got the multi-dose metronidazole had a 48% reduction in the odds of being repeat positive at test of cure. Also, there's a trend for women with baseline genital symptoms to have a greater odds of being repeat positive at test of cure if they got single dose. There was no significant difference in the odds of being repeat positive at test of cure among women with a baseline diagnosis of BV or with a diagnosis of gonorrhea. And then on the right, in the adjusted analysis, only the treatment arm and a history of trichomonas infection were associated with test of cure positivity. So basically, if you got single dose metronidazole and you had a history of trichomonas infection, you were more likely to fail treatment at test of cure. Next slide. So basically the conclusion of the parent trial, we know that multi-dose metronidazole is more effective than single dose. This did change national guidelines for the treatment of trichomonas in women. For this analysis, it's especially important that women with a history of trichomonas infection absolutely get the multi-dose metronidazole regimen. So that's the biggest risk factor to fail if you had to give somebody a single dose metronidazole pill, which we really don't recommend anymore. Next slide. The second study I'm going to talk about quickly is another clinical trial that we participated in for a new second generation 5-nitroimidazole, which you may all have heard of, which is oral secnidazole. This is the results of our clinical trial on that. Next slide. So secnidazole is this next generation, has a longer half-life, which is 17 hours, compared to metronidazole, which is 7 to 8 hours, and tinidazole, which is 7 hours. Oral secnidazole is given in a 2-gram single dose granule formulation. You do have to mix it in pudding, applesauce, or yogurt, and the patient has to eat that, whatever item they choose to mix it in, and then drink a glass of water afterwards. It had already become FDA approved for the treatment of BV in 2017, so it's already been out on the market. However, it did not yet have an FDA indication in this country for trichomonas. So we were thinking it could be an additional alternative for trichomonas and BV co-infection. Now that we're moving to multi-dose metronidazole as the primary treatment for both of those infections, we were still looking for single-dose alternatives. So basically, this trial evaluated the efficacy and safety of secnidazole in women with trichomonas. The primary efficacy endpoint here was microbiological cure by an in-pouch culture at a test of cure at 6 to 12 days. Next slide. Inclusion criteria here are adult women or post-menarcheal girls greater than 12 years. Diagnosis of trich determined by a positive NAT, a positive awesome rapid test, or a positive wet mount. People had to agree to abstain from vaginal intercourse until after the final study visit. They got excluded if they had VVC, symptomatic chlamydia, gonorrhea, or active genital herpes outbreak. And no people that did have BV were eligible for this study. As we know, Signatazole also treats BV. Next slide. The study design, they got 1-to-1 randomized to a single dose of Signatazole versus placebo. This was a delayed treatment study. This was stratified by site. So there were 10 sites participating in the study, UAB, which was 1. The study visits, we had a visit 1, which was baseline enrollment and randomization, and visit 2 was test of cure. There was also visits 3 and visits 4 to make sure women got standard of care treatment for Trichomonas if they were still infected. And to make sure everybody was doing well. But the main visits in the trial were visit 1 and visit 2. And at all of these visits, people got vaginal specimens, provider collected, they got the in-pouch culture, and then they got tested for gonorrhea and chlamydia. So basically the delayed treatment design, basically people got randomized either to Signatazole or placebo at visit 1, and then they got the opposite treatment at visit 2, which was 6 to 12 days later. So everybody in the trial got treated. I want to say that because we didn't want to enroll, it would be unethical to enroll people in the trial with a known STI and not treat them. However, we could not use NAT as our primary endpoint because at 6 to 12 days, the NAT would still be positive as dead DNA would still be present. Next slide. In our intent to treat population, we randomized 147 women. They got split into each of the groups. As you can see, 73 completed the Signatazole test, 73 that got randomized to Signatazole completed a test of cure versus 70 that got randomized to placebo. We had a couple people discontinue for various reasons. Next slide. So our primary endpoint, which was microbiological cure by culture at test of cure, was 92.2% in the Signatazole group versus placebo 1.5%. Next slide. For people, we split it up into symptoms. So for people who reported genital symptoms at baseline, the microbiological, the primary outcome was 92.9%. People who were asymptomatic at baseline was 87.5% in the Signatazole group. Next slide. And then we had some people in the study that were HIV positive. So there was 4 women in the study. All of those women had a 100% cure rate that got randomized to Signatazole. And then people that also had BV, the efficacy was 95.2% who had BV and Trichomonas infection. Next slide. And finally, for AEs during the study, AEs were similar to the BV trials of Signatazole. There were no serious AEs in this study. There's actually more AEs in the placebo group than in the Signatazole group. But the most common ones were just GI issues, just mild nausea. Next slide. So in conclusion, oral Signatazole was found to be highly efficacious for the treatment of Trichomonas, single dose. I've already went over the efficacy numbers. The AE profile looked good, no serious AEs. And Signatazole actually did get FDA approved for the treatment of Trichomonas in women in June of 2022. And they actually, the company that manufactures this drug actually used clinical trial data from Europe in their FDA application to also get it FDA approved for Trichomonas in men. So you can use it in both women and men in this country. I think that's all I have. Thank you all so much.
Hey everyone, I'm up next and let's see if I can advance this. Got it. All right, my name is Teresa. I'm one of the Gynonc fellows and I'm stepping in today for Dr. Aaron, who's currently out of town. So the first trial we're going to talk about is DETECT, and this is the discovery and evaluation of tests for endometrial cancer in tampons. So the incidence of endometrial cancer has been increasing in the United States recently, and we know that that's because of increased obesity in our country. And then also African or Black women are much more likely to have advanced stage and grade at diagnosis. And so we're trying to figure out ways that we could potentially diagnose women earlier that are non-invasive and potentially find a screening tool. So the goal of this study is to evaluate the potential of using a tampon that's self-collected and look at biomarkers that are found on these to see if they can diagnose cancer. So there are DNA mutations that they look at compared to a panel of the most common DNA mutations in endometrial cancer. The study is any patient who's over 40 and getting hysterectomy. So this is for both benign patients and then also patients who have cancer. They get a tampon in the pre-op area along with a survey, and then they insert the tampon in prior to surgery. And then when they're set up during the surgery, the tampon's removed. And then they also get a sample of blood that's sent to a central location where they then analyze it. And then they also get a questionnaire at their post-op visit. So the study is currently still in accrual. There have been 473 patients enrolled. About 65% of them are white and 30% are Black. Most of them are obese patients, and then about half of them have endometrial cancer, and then half are benign. So we are looking for more patients who have benign indication for surgery. And we have several research assistants and a nurse who pre-screen, especially in the gynonc clinic, but we're also looking for more from the CWRH and other benign clinics that might be going to the OR. So if you have a patient that you think would be eligible for this, you can actually send an impact message to one of these 3 people mentioned here. It's Jenna Moore, Jill Hyde, and Bailey Dover. If you have someone who you'd like to get involved, and then they'll kind of help set up all of the process for that. And then we're also looking at potential enrollment racial disparities in this project as well. The next study that we have is a new study that we're partnering with the University of Washington, and this is called the SISTER study. And it's looking at social interventions for support during treatment of endometrial cancer and recurrence. So we know that minority women sometimes have a harder time getting access to care, and then also have lower rates of completion of therapy. So the goal of this is to look into how potentially we can do a better job helping women who are a minority in order to complete their actual treatments. So looking at the difference between support materials, group support, and then individualized support, and then doing qualitative interviews to figure out which of these methods is the best. We're trying to enroll 252 Black women with endometrial cancer, and this is across 10 different study sites. They'll get 4 different surveys at their initial time frame when they're enrolled, then before their surgery or treatment, in the middle of it, and then at the end. There's going to be 3 different groups that women will be randomized into. So one will be that they'll just simply receive support materials. They'll get a care package that has kind of just basic information. And then the second group is looking at group support where they'll join a weekly group that's led by a peer supporter. And then the last one is one-on-one peer support. And overall, looking at the end results, we'll be looking at compliance with their treatment therapies, completion, and then also looking at the survey results to see which they felt the most supported in. And then I think Dr. Kimberlin is next.
Good afternoon, everyone. This 3 studies I'm going to be talking about today relate to neonatal HSV and congenital CMV. The first is a study that was done actually in adult women to sample the genital tract at the time of delivery among pregnant women to determine whether a rapid point of care PCR diagnostic could detect reliably HSV shedding from the genital tract. Next slide, please. The rationale for this study is presented on this slide and the following slide. With this slide, I want to point out that 85% of babies born who develop neonatal HSV acquire it during the birth process. About 10% are postnatal and the other percent are in utero. So the majority, overwhelming majority, acquire it during the peripartum process. And most of these babies are born to women who have no symptomatic evidence of disease or infection at the time of delivery. They have no active lesions that are visible at delivery. If you go back and talk to parents of babies who have neonatal herpes, the overwhelming majority of them, between 2/3 to 4/5, have no history of genital herpes. And so there is not a reliance on that can effectively identify babies at risk on asking parents for their parental history. So the rationale here is if you can't ask the historical aspects of it, and most women are asymptomatic, who are asymptomatically shedding, among those babies who get this rare disease, neonatal herpes, maybe we should be able to sample vaginal swabs at the time of delivery to actually determine who is shedding and therefore which babies are at risk. Next slide. The study was a large study. Vaginal swabs were taken at the time of delivery and placed in viral transport media and stored for possible testing. I should have pointed out that there's two different groups. So the group we're most interested in with this discussion are those that have no symptoms at delivery and are enrolling for swabbing. Next slide. 12,500 women enrolled. Almost all of them did have their vaginal swabs collected. About half of those were randomly selected for testing by a standard lab-developed test, PCR. And then those samples were also tested with the Cepheid Gene Xpert PCR that was an HSV cartridge that the Cepheid company developed for this study, NIH-funded study, but the Cepheid partnered by developing a research use only test. 204 of 6,658 samples were positives for about a 3.1% positivity rate among women who had no active lesions. And that's using any copy number for the HSV DNA and any CT value for the Xpert PCR. I'm not going to show you the analysis of that, but it came in at about 88-90% sensitivity for the Xpert PCR. And ultimately, Cepheid decided they did not want to invest further in the improvement of that particular cartridge. But they did connect me with a company out of Australia that has a plate. The company is called SpeedDX, and they have a plate that currently has authorization and approvals in the European Union and in Australia that can detect HSV DNA. So our next step was to evaluate the 204 samples that were positive by either or HSV DNA PCR or the CT or the Xpert PCR to test those for SpeedDX PCR along with 204 matching samples. Total of 408 samples, therefore, were tested, and using breakpoints of greater than 200 copies for standard PCR, that's our threshold of detection, and CT values of less than or equal to 37 for the Xpert PCR and or the SpeedDX PCR, there were 169 of the 408 that were positive. And next slide will show the breakdown of this. What I represent here is in the upper circle, this is a Venn diagram, obviously. The upper circle shows those positive by standard PCR. The lower left circle shows those positive by SpeedDX PCR, and the lower right, those positive by Xpert PCR. You can see that 92 were positive by all three, 14 were positive by standard PCR and SpeedDX PCR, but not Xpert, and 7 were positive by SpeedDX PCR and Xpert PCR, but not by standard PCR. And then there were 32 that were detected by SpeedDX PCR only. Next slide. So thinking about whether those SpeedDX PCRs could be false positives, I don't think they were. Looking overall, 86%, just shy of that, of the 169 samples was positive by SpeedDX, and you can see the confidence intervals there, compared with 65% and 74% for the Xpert and standard PCRs, respectively. Looking at the 92 samples that were positive by all PCRs, the median viral load was almost 23,000. And importantly, the median CT values were 22 for SpeedDX and were much higher at 32 for Xpert PCR, indicating that for those that we know were positive by all three, the SpeedDX PCR was more sensitive, which gives me optimism that the SpeedDX assay might allow us a way to move forward with this type of approach. Next slide. Next study is a biomarker study, an attempt to identify biomarkers in babies with congenital CMV. Next slide. Next slide. The rationale here is that the drugs we have to treat congenital CMV are ganciclovir and valganciclovir, and these cause, in at least some animal models, cancer. We've not seen that in humans, but we definitely do see neutropenia in between 1/5 to 2/3 of babies receiving these drugs. And in order for an antiviral program to have maximal impact on CMV-associated hearing loss, congenital CMV-associated hearing loss, we really need to focus in on the asymptomatic congenital CMV population, since more than 2/3 of CMV-associated sensorineural hearing loss is in babies who are asymptomatic at birth. So we have to have a better understanding and definition of the risk-benefit ratio for who is at risk among the asymptomatics. And to do that, we would need a biomarker. Next slide. So looking at the subset of infants who are asymptomatic at birth and at increased risk of sensorineural hearing loss will facilitate subsequent design of studies by concentrating those babies at higher risk and therefore yielding lower sample sizes that would be required. So the current study is to identify such biomarkers if possible. Now, the final sub-bullet is an important one. There has been already a publication in a science journal from Asun Mahias at Nationwide Children's, who is partnering with us, and she has a transcriptomic biomarker signature that is suggested to have 92% accuracy in identifying infants symptomatic or asymptomatic at birth at risk of developing or who will go on to develop sensorineural hearing loss. And so we will include a validation data set for this. Next slide. Inclusion criteria basically are just that you have to have CMV rather detected within the first 30 days of life, therefore defining one as a baby with congenital CMV infection. Next slide. The design is as follows. We have a screened population and a referred population. The screened population are those where we obtain consent from moms to have the babies delivered who have no symptoms whatsoever, no reason for us to think about congenital CMV, to swab their saliva for a CMV PCR. So these are likely going to be babies that are asymptomatically infected, and we anticipate about 40 subjects will enroll. We also have a referred population, those babies that maybe were outborn babies and were identified as having CMV, therefore likely are symptomatic babies. And we anticipate about 45 of them enrolling. Next slide. Outcomes will be the transcriptomic signature that I mentioned from Dr. Mahias. We'll also be looking at viral load and viral subpopulation assessments, T-cell responses in the moms and in the babies, and avidity assay determination for maternal antibody to determine whether she has a more recent infection or a long-standing past infection. Next slide. We currently have enrolled 8 subjects on the study, 7 of them from here at UAB. The other was a Florida baby that was enrolled yesterday. Sites are being activated, and we've already started having monthly calls so that this study can continue to pick up steam. Next slide. Final study is a carry forward from the study that we just talked about, one back with respect to detection of HSV DNA at the time of delivery. What I would like to do ultimately is to be able to detect a woman who is shedding HSV at the time of delivery and then have a preemptive therapeutic intervention in the babies born to those women, the babies that are exposed to HSV DNA at the time of delivery. We have to know how to dose valacyclovir in the neonatal population to be able to have that therapeutic intervention. So the current study I'm going to be talking about for these next couple of minutes, the study is a phase 1 multi-dose PK and safety assessment of valacyclovir in neonates. Next slide. The rationale here is, as I've mentioned, if you could detect women shedding at delivery and you could then intervene with an antiviral that was safe and reliably produced acyclovir concentrations that could block exposure from ever progressing on to infection and thus to disease, we might have a way to stop 85% of neonatal herpes. Next slide. The primary objective of this study is really very simple. It's simply to determine the dose of valacyclovir that reliably gives systemic exposures comparable to a lower dose of intravenous acyclovir. We also are looking at pharmacokinetic profiles of acyclovir in neonates receiving valacyclovir in order to meet the primary endpoint, and then also to look at the safety. Next slide. Inclusion criteria are really quite minimal. we are approaching women who have a history of genital herpes and are on suppressive therapy themselves. The rationale there is twofold. Number one, they're going to be familiar with HSV. They're going to be familiar with antiviral treatment of HSV, and therefore it might make them more likely to want to participate, which would be good from our standpoint. And there's at least a theoretical risk that women, even on valacyclovir or acyclovir or famciclovir suppressive therapy at the time of delivery, still could be shedding and still could therefore transmit the virus to the baby, and therefore it helps with the risk benefit for this PK study. We're going to start or enroll within the first 2 days and start drug during that time period. Next slide. There are 2 cohorts. The first is getting a lower dose valacyclovir, 10 per kilo. They'll get it for 5 days. The drug may be started in the birth hospital, and we'll do PK assessments on days 1 and day 5. Day 5 is the full PK profile, and then we'll have some follow-up evaluations to make sure they've not had any problems from a safety standpoint. Next slide. And then assuming that that cohort does not hit our dose parameters that we have predetermined for the study, we may increase the dose and do the same thing again with an additional 8 subjects. Next slide. And this is my final slide. This has cleared the FDA. Site here at UAB has been activated, and we're undergoing screening currently, and other sites are being activated currently. And I'll now stop and turn it over to Dr. Tita.
Thank you, David. Can you hear me online? Anyone online, can you hear me?
We can hear you, yes.
All right, terrific. Thank you. So yeah, I'm going to give some FaceTime in the room, and I want to thank all of those who already presented. My name is Alan Tita. I am the director of CWRH, and it's always really fascinating and fantastic to see what may be coming down the pipe or not coming at all. So as we get ready to do this, I want to thank again all of those who presented. All right, terrific. So I have just 2 studies to present. One is TXA for prevention of postpartum hemorrhage. This is one that was done by the MFNU network, and very proud to say that UAB participated in this, and you all did the enrollment, you all did the consenting, you all made us #1 out of 31 different sites nationally in this study. This was presented last year at SMFM and will be coming out in a major journal shortly. So I'm going to whet your appetite. So what was the purpose? The purpose was to test the hypothesis that prophylactic TXA for cesarean delivery decreases the need for transfusion of fat red blood cells, and also as part of the composite was maternal death. And this was a multi-center trial, patients undergoing cesarean delivery, both scheduled and unscheduled cesarean delivery, assigned to 1 gram of TXA or to placebo immediately after cord clamping. And our goal was to give this within 10 minutes of delivery, and 92% of the time we did. The primary outcome, again, composite of death or transfusion within 7 days. Secondary outcomes included your definition of postpartum hemorrhage, hemoglobin change before and after delivery, hospital stay, and the sample size was 11,000, 85% power to detect a 33% reduction. And so what did we find? So at the end, we enrolled just almost the 11,000. I think there were a few, we went over 11,000, but a few had to be dropped off, and 5,000 in each plus in each group. 50% of this were scheduled cesarean. So 50% of these were unscheduled cesareans. And as you all know, a challenge to get unscheduled cesareans enrolled. That's where we were very successful. Yeah. And the primary outcome was 3.6% in the TXA group, 4.3% in the placebo group, 0.85, so just only 15% potential reduction and not statistically significant. But you can see it's really close there on the upper limit. I think, with final analysis, this is from the presentation at SMFM, with final analysis, it may be about 1.07, but really very close. So the question will be, what do we get when we end up doing meta-analysis with other studies that may be out there suggesting that TXA helps? Treatment, uterotonics, battery balloon, all other interventions that we implement were reduced significantly by just about 10% from the relative risk of 0.90, confidence interval at 0.99 upper margin. There was a change of a reduction in the drop in hemoglobin in the TXA group, shown here now. Whether this is clinically meaningful or not will have to be further determined when you look at higher hemoglobin levels. But on average, the mean there was about 1.75 to 1.87. So we're talking about a 0.1, approximately a 0.1 hemoglobin drop. There are no differences in other outcomes, including VTEs, obviously small numbers that we tend to get concerned. So that's it for TXA, and look out for it coming soon. Now I'm going to talk about an ongoing study, the progesterone and pessary for cervical shortening in twins, that is still ongoing. As you all recall, we were also participating in a pessary study in singletons that got stopped by the Data Safety and Monitoring Board. And that study, the TOPS trial, will be presented at SMFM in 2 weeks. We had to scale back on the number of studies we are presenting. So watch out for that. We are also at SMFM in 2 weeks presenting long-term outcomes to the ALPS trial, as you recall, the ALPS trial, corticosteroids versus placebo for late preterm birth. So what happens in the long term is steroid safe. So we have that answer, and I hope we have another opportunity to discuss those findings. But this is still ongoing. Primary question in women with twins and short cervical length, defining twins as less than 30 millimeters, prior to 24 weeks, does treatment with an Arabic cervical pessary or a vaginal progesterone prevent preterm birth less than 35 weeks? And that obviously defines the primary outcome. It's a multi-center 3-arm trial. Our sample size is 630, including twin gestations, again, with a short cervix as defined there. And then you can see the 3 arms, including the option of the vaginal placebo, as well as the 2 active arms of pessary or vaginal progesterone. So again, as I said, it's ongoing. We've enrolled, we started in 2016 or so. We've enrolled 385 of the 630. It's obviously twins, low prevalence. And we've enrolled a bit just under 10% at UAB, 35. And in the last 4 months, we've not had anyone enrolled in this trial, which is still ongoing. And you can see on the right hand there a cervical Arabic pessary. So how can you help? Notify the research team when you have twins. They're obviously always looking, but also, new twins coming into the system, let them know, and we'll do an additional outreach around this. One of the key things is currently our standard for twins is ordering this transvaginal cervical length and making sure we don't miss them. But also importantly, again, check with the research team, including for patients who are already enrolled, as you make decisions about how to manage the pessary or progesterone. And then most importantly, the pessary must come off. And then prior to delivery, and for a C-section, again, prior to delivery or absolutely before the patient goes home. And I know why people are laughing. All right, so that's it. That's it for today. Again, I just really want to thank you all for your attention. I think many of those who presented are online, and we can take a number of questions. This prospect trial is one that is being led by us at UAB as the lead site. It's a proposal that we put in Joey Bishop while he was still here, and he continues to be part of that leadership. So UAB within the MSPH network leads prospect trial. We have an investment in making sure that it succeeds. All right, so thank you. And are there any questions? And for those online, also feel free to drop in questions in the chat box, and I'm happy to get them moderate, or Dr. Richter is there as well can moderate. So any questions from people?
I have a question for Dr. Muzny about the cost of the Metronidazole irritant.
You have it for who?
For Dr. Muzny about the Cytomegalorivus study and the cost of that compared to the Metronidazole.
Dr. Muzny, what's the cost comparison between Cytomegalorivus and Metronidazole?
Yeah, so there is a significant cost difference. Oral metronidazole is generic. It's the cheapest treatment for any STI. So, I mean, we can get it between $4 and $7, and Cytomegalorivus is $220. The company does have patient drug assistance programs, and it's I mean, there's a risk benefit thing, if somebody wants to take a pill one time for BV and Trichomonas versus having to take a 7-day treatment, they may want to pay more money. A lot of people are probably not going to want to pay more money. But the cost is kind of what it is.
Yeah, thank you. Really great question.
My question is also for Dr. Muzny, talking about expedited partner therapy, which is not allowed here. Is that allowed in Louisiana? And how did the partner testing and recurrent sexual activity factor into the study?
Christina, did you get that?
Yes. So that trial the parent trial that I was talking about actually had 4 arms to start with. When it was an R1 from NIH. It actually had 4 arms with 2 EPT arms. And because Alabama does not do EPT, they had to take out EPT in the trial because of us, basically, because we're doing it here. Alabama basically enrolled the highest number of participants in that trial. We enrolled 450 of the 623 participants in that trial. And so sadly, we didn't do EPT in that trial. And it's very unfortunate that Alabama is like one of the 4 states in this country where we're not doing EPT.
All right. Any other questions in the room? I don't see any in the chat box. All right. Thanks, everyone.